This presentation is on the psychotropic medication use among children and adolescents in America. I like to preface by stating that this area of study is very extensive, and although I will be trying to provide some supplemental material that I hope you find beneficial, I highly recommend looking into this subject matter more, as I will only be able to scratch on the surface of this highly debatable and controversial topic. An estimated 68 million children are taking psychotropic medications, which is about 8 to 10% of the 0 to 18 age population. You can see that since 1996 there has been a steady increase in the use of multi-class psychotropic medication, which is when a child is prescribed more than one psychotropic medication from two different classes of psychotropics. For example, co-prescribing a child a stimulant and an antipsychotic at the same time. It's estimated that only 30% are approved by the FDA of these psychotropic medications. So in other words, that means most medications are being prescribed off-label and are normally being based off of adult studies when they're prescribing them to children. Studies show that at least 1 in 5 children has a mental, emotional, or behavioral disorder severe enough to cause some level of impairment, with current prevalence estimates of child psychopathology ranging from 13 to 21% of the pediatric population. First, I have listed the estimated top percentages for the psychiatric disorders among children. And they're listed in order of their prevalence rates among this pediatric population in America. The important thing to note here is how high the prevalence of ADHD is compared to other disorders. Among children, ADHD is roughly estimated to have a 7% prevalence rate, but some results estimate the prevalence of ADHD to be as high as 12%. Roughly 2 to 6% of preschoolers are diagnosed with ADHD. Of these, 60 to 80% will experience ADHD symptoms in adolescence, and 60% will experience ADHD symptoms in their adulthood, with an estimated 4% of the adult population having ADHD. Unlike earlier schools of thought, ADHD is now considered a lifelong disorder that often extends into one's adult life. It's important to note that the manifestation of ADHD symptoms in adults appear different than that of childhood. For example, hyperactivity in adults does not often manifest the same way it does in children, as adults may have learned social constraints or to simply avoid situations that require them to sit still. So among the foster care system, the rates for psychotropic medications are staggering. Children in foster care are prescribed psychotropic medication 3 to 11 times more than non-foster children. Children in foster care are prescribed antipsychotics 4 times more than that of the general public, making antipsychotics a huge concern among this population, and this is a new concern. In a 2009 study that was done within the state of Florida, they found that 15.2% of the state's foster care children were prescribed psychotropic medications. And that rate was a rate 3 times that of the general population in Florida, and that would be among children. A 2008 national survey involving psychotropic medication among foster care children yielded the following percentage rates in reference to the number of psychotropic medications being prescribed to these children. Note the high rates of polypharmacy, especially among those that are involving 3 and even 4 types of psychotropic medication among foster care children. I mean, we're talking just really, really high percentages across the board. While it's no question that children in foster care are being prescribed psychotropic medication at alleviated rates compared to non-foster care children, There is some debate over whether this population is just being over-medicated and misdiagnosed, or just a highly representative population of psychopathology due to their early childhood experiences. Among foster care children, it's estimated that 40% of foster children have a history of physical abuse, and 20 to 30% have a history of sexual abuse. Among those in residential treatment, it's estimated that 97.6% have had a background of abuse. Abuse is often linked to a confounding number of social and emotional and psychological problems, and thus rates of psychiatric and mental health disorders are estimated to be 3 times higher among children with a history of abuse. And so the idea is that this high level of abuse with foster care children sort of puts them at a higher rate of having some sort of psychological disorder, and then at a higher rate of needing these mental health services and needing psychotropic medications. It's estimated that 80% of the foster care population has a mental health problem compared to the 18 to 22% among the general population. Yet only 23% of foster care children receive mental health services. Thus, many foster care children are not receiving adequate services, while at the same time a staggering amount are being given multiple psychotropic medications that could potentially be harmful to them. Since the 1990s, there's been an increase in the use of psychotropic medication among children. While there is some debate over the short-term effects of these psychotropic medications, there are even more staggering concerns centering around the long-term effects of psychotropic medications, especially on the developing mind of young children. Many of these medications are prescribed to children off-labelly. In other words, they're being prescribed when they haven't been studied or FDA approved for the use of children. In addition, the younger the child is, the more likely they are to be prescribed psychotropic medications on an off-label basis. The FDA addition of the black box warning label for the SSRIs in 2004 due to the increased rate of suicidality among children and adolescents is a great example in which off-labeling and prescribing children medication solely based on adult studies can have extremely negative effects on this population. Many of the medications that are used and offer multiple negative side effects, with the most extreme including death, heart attack, suicidality, psychosis, and even induced mania or manic episodes. So in addition, some parents are also not informed of these risks by their healthcare providers, and so there's this lack of information being facilitated to parents, not only in the options that they have, but also in the risk benefit, and they're not really considering this risk benefit. Among the pediatric population, stimulants, antidepressants, and antipsychotics are the most commonly used psychotropic medications. Another ethical issue centers around the false reporting of results done by controlled studies involving psychotropic medication. For instance, in 2002, 57% of drug studies published in medical journals were funded by pharmaceutical companies, compared to the 25% in 1992. Results from the 2002 study demonstrated that research results yielding favorable outcomes for the drugs being studied were approximately 8 out of 10 when they were being funded for by the manufacturer of the drug, 5 out of 10 when they were being funded by the company with no industry support, and 3 out of 10 when they were being funded by a manufacturer of a competing product. So as you can see, it appears that there's been some sort of almost lying and misinterpreting and reporting of information. And so especially in this area, when you're researching information, make sure you're always checking out like where are you getting this information from, and to know and have ahead of time, like, okay, this is being done by a pharmaceutical company, like, is there an underlying motivation going on here? The rising increase of children and adolescents being prescribed psychotropic medication has sparked controversial debate of whether or not we should or shouldn't be prescribing children psychotropic medications. Like most controversial topics, there are two sides that offer differences in opinion. The pro side, which argues that we should prescribe psychotropic medication to children, feel that the use of these psychotropic medications by children and adolescents, as prescribed and monitored by competent healthcare professionals, has major beneficial effects. They argue that these disorders are a result of biological deficits, which cause serious impairment in one's life, and thus medication, which alters underlying biological deficits, are effective in alleviating these negative symptoms. They believe that these disorders are on the rise and that it's unethical to not provide effective and science-based pharmacological therapy to an individual, even on a symptom basis. They believe that the risks for using these medications are known, understandable, and controllable. We should continue to refine and improve our knowledge of these agents through research and evidence-based practice. The con side, which argues that we shouldn't be prescribing children psychotropic medication, feel that the risk of these medications do not outweigh the benefits. As they say, the risks to children are not known, especially the long-term effects on a child's developing mind. They feel that the mental health field is a giant hoax that has resulted from a consumer-driven medical industry whose main goal is basically to make a profit. They argue that the medicalization of what are often or what used to be considered normal aspects of behavior are now just repercussions of an out-of-control drug industry and a quick-fix culture that has resulted in artificial diagnosing and an epidemic proportion of children and adolescents being prescribed psychotropic medication. For my presentation, because I'm doing it on psychotropic medication, I was supposed to present my thought on the idea and this controversial debate, and then sort of give you my information to sort of back up my personal view. So after I thoroughly researched this topic, as the information is pretty dense, and I sort of looked at both sides of the debate, my personal view in whether we should or shouldn't prescribe children psychotropic medication sort of takes on more of a middle-of-the-road perspective, as I believe that there are beneficial effects to using psychotropic medication when individuals are being properly diagnosed, treated, and monitored. However, I also feel that the medical pharmaceutical industry has become a consumer-driven industry that has increased the misdiagnosing and over-medicating of children. So to break it down a little bit more in my thought process of what's been going on, I believe that for most mental health disorders, I believe that there are underlying biological deficits, at least to some degree, because I do think, yes, that environment definitely plays a role as well. But with the underlying biological deficits, I think that when they're properly diagnosed and treated and monitored, the individual effects can be profound and beneficial. I think that anyone who's worked with children and adolescents, we've witnessed this firsthand. We've witnessed the benefits firsthand. And I mean, it's great to see children like kind of just do a 180 and feel so much better about themselves. And I feel like in that sort of a sense where it's doing good, like that's a good thing. But at the same time, I have to also preface and say that, however, while in theory, properly diagnosing, treating, and monitoring a child on psychotropic medication sounds great, the problem is these things don't often occur in practice due to time demands, societal ideals, pressure from patients and their parents. And this is largely driven by an industry which focuses on marginalizing its profits. And thus, all of this has led to, a large majority of children being misdiagnosed a lot of the times, over medicated, and improperly treated. And so I think there's kind of this counterbalance that we have to try and find a common balance between the two. With antidepressants, just to start off, as previously mentioned, there are three main classes of psychotropic medications, which are the stimulants, the antidepressants, and the antipsychotics. While there are various psychotropic medications, I'm just going to briefly touch on the main ones just to give you kind of a idea of what's going on and the main psychotropic ones for each class. But I would recommend that you please refer to my handouts for some more information, as I did try and provide a lot of good information. For antidepressants, the use of antidepressants has slightly decreased since 2004 due to the FDA adding a black label warning for the increased rate of suicidality among children and adolescents. Um, Also, with a lot of SSRIs, when they do randomized controlled clinical trials, the placebo control group often has a really high rate, due to the placebo effect, and so they have a really high efficacy rate normally too, and so sometimes there's not a significant difference between an SSRI and a placebo, and this happens a lot with SSRIs. But here nor there, among children, fluoxetine is the only FDA-approved psychotropic, antipsychotic for depression. Studies have found that fluoxetine plus CBT is superior, to either fluoxetine or CBT alone, and fluoxetine is superior than CBT alone. So if you were to separate the two, fluoxetine shows to be a little bit more effective than CBT. Um, Fluvoxamine and sertraline are also antidepressants. They're used for treating OCD and separation anxiety and generalized anxiety, for the ages 16 to 17. With antipsychotics, the annual number of U.S. children that are being prescribed antipsychotics between the ages of 2 to 18 has jumped fivefold, and it's estimated that about 2.5 million children are being prescribed antipsychotics. So over the past few years, really starting towards the end of the 90s, early millennium, just a high increase in the number of children being prescribed antipsychotics. Antipsychotics, they're often used for behavioral problems, autism, bipolar 1 disorder, and schizophrenia. And one of the bigger issues is the fact that they're prescribing these medications for behavioral problems. Even though it has been shown to be effective, sometimes they're using it as needed. So if you ever see anything where it says PRN, that's the medical coding that states to prescribe as needed, basically, and to take the medication as needed. So sometimes, like in foster care, when these children are acting out, they're giving them antipsychotics in order to calm them down. So just kind of keep that in mind. And then these medications also have really negative effects. They can induce psychosis, manic episodes. A lot of kids don't really like taking them because I guess it makes them increase weight, and because that increases their hunger a lot. Risperidone is the only FDA-approved antipsychotic for children. Although it has been shown to have high efficacy and be well tolerated, many are concerned about the long and short-term effects this drug has on the developing brain. And unfortunately, most of the research in this area has involved animal studies. So there's been a few different animal studies, one of which has looked at the short-term effects of these medications with rats. And this study found that it increased different densities based on the receptors. So within the forebrain, it was increasing dopamine and glutamate receptors. And then in the hippocampus, it was increasing serotonin receptors. Um, and then another study wanted to see what were the longitudinal effects in having um, individuals put on risperidone for an extensive period of their whole entire developmental period. They put the rats on these medications to see what happened. And so they ended up finding that the rats were very hyperactive throughout the whole entire thing. They were hyperactive. Um, and the results sort of yielded that this increased hyperactivity in both male and female rats was an effect that even lasted several months after they had stopped the treatment of Risperdal. And it sort of indicated that early life risperidone treatment exerts selective but persistent effects on behavior during adulthood. So with stimulant medication, approximately 3.5 million youth are taking stimulants for ADHD, with an estimated prevalence rate of 3 to 20% among the ADHD population. Stimulants are the most well-studied and effective psychotropic medication for children. Stimulant treatment for ADHD began in the 1930s with open amphetamine trials. These early trials led to more well-established stimulants in the 1970s. So these original stimulants in the 1970s were immediate releasing forms that had short half-lives and required multiple dosing. So a half-life is really how long it takes the medication to metabolize in your body, and basically how long does it take for you to get rid of half of the medication and metabolize half of the medication. Then with the first generation stimulants that came out after the original stimulants, these were formulated to address the shortcomings of the immediate releasing forms of stimulant medication. And so they wanted to create a long-acting formulation of this. And although the initial study of the first generation stimulants showed it to be superior to placebo, later studies showed no difference between first generation stimulants and the placebo group. So thus, the second generation stimulants were formulated in an attempt to create more effective long-acting stimulants. Overall, stimulant medication yields high response rates with roughly 90%. And behavior therapy has been found to be not as effective as stimulant medication in treating ADHD. However, it does have some effect, and it has been suggested that behavioral treatment is used as a first line of treatment for mild forms of ADHD and preschool children. Um, One interesting thing that I found is studies have also shown that children receiving both behavior therapy and stimulant medication were normally on lower doses of stimulant medication than those who were only receiving medication. So it seems like there might be something else going on, and I felt like that was pretty interesting. Among stimulants, there's quite a lot of new stimulants, so I'm going to go quickly through this. With Focalin, basically original forms of methamphetamine had two types of ingredients in them, but later studies kind of indicated that only one of those ingredients was the active therapeutic agent. And so thus they formed Falkland, which only contains one of the two original ingredients, the one that they felt was the active therapeutic agent. With the mixed amphetamine salts, these are your common Adderall, the extended release ones, If you've ever seen them, they have the little beads in them. Basically, what happens is it's like 75 to 35%. 35% is the immediate releasing, fast acting amphetamines, where 75% is the long acting amphetamine. And so it gives the patient, it's not only quick and fast acting, but it also extends for a long period of time, and it gives that person sort of the best of both worlds. The methamphetamine transdermal was a really interesting. It's a new patch or transdermal patch that was formulated, and it has a 9-hour wear time. This is really significant because, unlike oral stimulants, children can remove these and stop the effects of the medication, as you know, and it makes it more specific to treating that specific child, where when you take an oral medication you can't necessarily stop metabolizing it inside of your body. So it's like a great new thing, I think. Strattera is a norepinephrine reuptake inhibitor. So it's the only non-stimulant medication that's used in treating ADHD. It's often used with children that maybe have comorbidity with seizures and things like that, or tics or anything where they're afraid to give them stimulant medication. The only problem is that it's been shown to take 1 to 2 months for the effects to kind of show up with this medication. And then the last two are alpha 2 androgenetic receptors, and they're often used to treat comorbidity as well with ADHD. And they're often used in conjunction with another form of stimulant to kind of help with some of the side effects that some children may experience. Unlike most psychotropic medications, the efficacy of stimulant medication among ADHD individuals is not the primary issue. Problems arise in the question as to whether or not we are misdiagnosing individuals as having ADHD. For one, this disorder mimics many disorders. For instance, a child who's been abused and experiencing PTSD may exhibit similar inattentiveness often demonstrated in ADHD individuals. Since stimulant medications are so effective and used as a first line of intervention, improper diagnosis can have large negative effects on a child. There's also the concern as to whether or not children are being medicated so they can control behavior problems for these children that don't adhere to socially constructed norms, or even if these medications are being prescribed to and or abused by children in order to enhance their academic performance. While stimulant medication has a magnitude of negative side effects, the increased risk of cardiac-related issues, sometimes leading to sudden death, along with the increased risk of manifesting psychotic symptoms or even mania, are highly controversial. In addition, suicidality can occur among children who suddenly stop taking stimulant medication without proper psychiatric monitoring and titration of the drug, and that's because the stimulants are really affecting the dopamine in a large portion of the child's brain, which is often associated with happy feelings and that happiness we sort of feel. And so by stopping that medication, they may hit really low levels of dopamine, and that sort of pushes them over the edge and can cause them to enter deep states of depression. And so that's definitely one thing to look out for if you're working with a child that they're trying to get off of ADHD medication. Among ADHD children, and among the ADHD population, studies have demonstrated both structural and functional brain abnormalities resulting in common characteristics between that of the ADHD and the non-ADHD individuals. Structural differences found in individuals with ADHD include areas within the frontal, striatal, parietal, and cerebellar regions of the brain. These studies have found that ADHD individuals often display delayed growth in some brain regions. So, for instance, within the cortical region, they've noticed a lagging of 3 years. Within the frontal region, a lag of 4 years, and within the temporal region, a lag of 5 years, compared to that of normal child brain development. There are many concerns regarding the effects of stimulant medication on the developing brain. However, so far, research on brain abnormalities have yet to demonstrate any significant issues with medication use, at least with the stimulant medication. In fact, they often demonstrate the exact opposite and show that children that are using stimulant medication are actually fall in between those that don't have ADHD and those that do have ADHD but aren't on medication. So, for instance, one specific study found decreased total white volume matter as well as decreased cerebral and cerebellar white matter volumes were significantly lower in non-medicated children when compared to both medicated ADHD children and the control um, population. And of course, the medicated children with ADHD fell in the middle. Most brain studies still do demonstrate smaller cerebral, cerebellar, and total white matter volumes among ADHD patients, so they do still see that across the board. As far as cool and hot executive function abnormalities go, these have to do with certain networks in the brain. The cool cognitive networks of dysfunction in ADHD include various brain regions and networks that mediate functions such as motor response and inference inhibition, cognitive flexibility, temporal foresight, selective and sustained attention, working memory, motor and timing process, etc., etc., etc. Hot executive functioning network has showed dysfunctions in ADHD patients that have been observed in the context of temporal discounting, reward processing, and reward anticipation. In addition, most of these brain abnormalities persist into adulthood, which again correlates why they think that ADHD is a lifelong disorder. Research has also found that there are decreased dopamine levels within an ADHD individual's brain. And this is why they believe that stimulant medication is so effective, because stimulant medication increases dopamine levels that are thought to be really low among these individuals. These decreased dopamine levels displayed among ADHD individuals also explains why these individuals find it difficult to sustain attention, as they often have a higher reinforcement threshold for things that most individuals automatically find rewarding and motivating, in order for them to sustain task and sustain attention. These brain abnormalities, along with the heritability rates of ADHD individuals, demonstrate that there are some sort of biological underpinnings, and there's heritability rates of ADHD with roughly it being 76% heritable. And so when you kind of put it all together, it kind of brings about the sense of, if ADHD is being properly diagnosed, and stimulant medication does help individuals who suffer from these abnormalities, it will help them in a sense. And then with the bipolar population, because this is also a highly controversial population, this is why I've talked a lot about both the ADHD and bipolar population. They are both controversial when having to deal with or when talking about the prescribing of children, prescribing children psychotropic medication. And so there's controversy over the issue of what to diagnose or what people are diagnosing individuals with bipolar disorder. And that may often lead to misdiagnosis. So some people are diagnosing manic episodes as being within childhood, episodes where children are lashing out and sort of like acting defiant, going back into these behavior issues. But with children who do display, very similar symptoms that are noted in adults during manic episodes, um, they've done studies where they've also noticed volume differences within the bipolar population. The top two with the decreased prefrontal cortex volume and the increased globus pilatus. Both of those areas are highly consistent with results, and then also decreased cortical gray matter and increased basal ganglia volumes have also been found, but they're not as consistent as the first two. Activation, with as far as looking at it from neurological firing and perspective, in areas involving motor and cognitive inhibition, impaired decision making, and risk taking. So they found different abnormalities within the motor and cognitive inhibition areas, and as well as decision making and risk taking. There's also an interesting, they've, with a lot of the studies, they've been able to kind of pinpoint now there's definitely a great amount of overlap between the four that I have listed down below: ODD, CD, bipolar, and ADHD. Um, but at the same time, there's also a great amount of differences between those. So while there is a good amount of overlap, they have also noticed different brain abnormalities between these, which kind of indicate maybe some biological underpinning between all of these disorders, that are often commonly lumped together a lot of the times with children. The last thing I want to talk about is basically more of a social aspect and a global aspect, and more of the economic aspect of this issue. So, the goal of the medical pharmaceutical complex has changed from creating health to creating wealth. They have shifted from discovering treatments for major disorders to medicalizing aspects of the human condition. This medicalization involves defining a problem in medical terms, employing a medical framework to understand it, and using a medical intervention to treat it. In today's society, much of what was formerly considered normal behavior in childhood, such as temper tantrums, excitable behavior, and sporadic mood swings, are now being diagnosed as a mental or behavioral disorder. Childhood has thoroughly been redefined. Character and temperament have been removed from the human personality, and virtually every undesirable childhood behavior has taken on pathological and diagnostic significance. In the psychiatric community, um, if they are wrong, or if they end up being completely wrong, then we have a generation of parents who have been deluded, while millions of children have been sentenced to a lifetime of ingesting powerful and dangerous drugs. With a profitable medical industry that seeks to expand the definition of the problem in order to sell more products and services, one day we might all be classified as at risk. This expansion in defining mental illnesses is demonstrated in the increasing mentally ill population. In 1954, 1 in every 480 Americans had a mental illness. In 2006, this number jumped to 1 in every 50 Americans. As the definition of mental illness expands, society's tolerance of abnormal behaviors and pathological symptoms decreases. The real-time world of clinical practice is a two-way street in which the careful measured criteria of diagnosis and prescription intersects with the increasing demand of services within a vast and growing healthcare industry. The pressures of time and business often trump evidence-based criteria of practice, thus accounting for the disparity one often sees between what ought to have happened in prescribing psychotropic medications to children and adolescents versus what actually happens. In addition, this situation is compounded for psychiatrists who specialize in treating children and adolescents because the reimbursement rates don't cover the extra time it takes to interview parents, caretakers, teachers, and others familiar with the child's behavior. Healthcare services shape and in turn are shaped by a number of social cultural factors. We live within an individualistic society in which useful behaviors consist of the skills and attitudes that enable an individual to compete in the emerging global economy. The idea is that children must be prepared for the modern workplace in order to compete successfully as consumers. Children who do not conform to the ever more restrictive and socially acceptable standards of behavior become problems that must be addressed. While some parents who have the skills and are willing to take the time to sort through the issues before turning to medication, others are perfectly content in getting a prescription that provides immediate relief and then dealing with the recommended counseling component later. Later, of course, never comes. The symptoms are gone, the behavior has improved, problem solved, at least for now. These parents insist that their child be put on psychotropic medications to fix the immediate symptoms until they can figure out what's really going on. But best practice guidelines all stress that it takes investigative work to sort through the combination of biological, social, and environmental factors impacting the problem behavior. Then again, there are the parents who, although highly educated and wealthy, put their children on meds in order to improve their academic performance. On the flip side, some parents are only presented with the option of prescribing their children psychotropic medication. They are never told of alternative treatment options, and some are never informed of the possible negative consequences associated with psychotropic medication. We've sort of enhanced or gone into this world where it's become we just want a quick fix, and we sort of eluded ourselves to believing that doctors have this special cabinet full of these pills that will fix all our problems and there'll be no consequences to using any of these. And so I think the big thing is to kind of sort through some of that and find a common medium. I thank you for listening. I know I definitely need to cut out some stuff, so I would definitely really appreciate, for those of you that did watch this video, if you could help me out with finding stuff to cut out. I've been overwhelmed with the mass amount of information. It is a lot of information, and at least for you guys, I wanted to try and provide you with some information that I thought would be helpful. So yeah, thank you for listening, watching.